ma'am is here to make that for all of you. So thank you, ma'am, for accepting the invitation. She is professor and former head radio diagnosis at SGRDH Amritsar. She is senior MRI consultant at Nijar Scan Center Amritsar. She has various publications in national and international journals and various lectures to her account. As we all know, she has written chapters in various books, Indian textbook of radiology, and she's member of all the prestigious societies across the world. So thank you so much, ma'am, for accepting the invitation and taking time out for this amazing session. I really always enjoy this somehow.
Thank you, Ankita. That's for your introduction and for being patient to be able to listen to it again. But this time, okay, for the audience, I've made it a little interactive. So we are going to start seeing the cases to begin with. And I want all of you to participate in giving me and trying to look for the findings in the radiograph that I keep showing you. Please remember, I'm not interested in a stat diagnosis because that is not the idea of this talk here. The idea is whether you pick up all the findings, and if you are able to see the different findings and pick those up, then only you can reach a differential diagnosis and of course reach the final diagnosis. So I think I'm going to start with the first case that I have. There's a 45 years old lady presenting with backache and generalized aches and pains, and you're provided with radiographs of the pelvis, hand, and skull. Okay, so I'm going to give you about 10 seconds to look at the radiograph and start writing, and I'm going to read out the names of those who get them correct, and I hope we have more and more participation as we go further. The cases are actually quite simple, so there's no need to think that I've got some very weird or bizarre cases. They're very simple cases, and I'm going to start with the first radiograph, that is of the hand. I hope you can all see that. I would like people to come in. Yes, we have Ishita coming in who says there's a diffuse osteopenia. I have somebody saying there is a diagnosis. I told you before that I really don't want the diagnosis to begin with. We'll reach a diagnosis after we've seen something. Yes, very good. Divya and Divya comes up with subperiosteal resorption. Very good. We have Vaseem saying acroosteolysis. Again, a very good pickup. Madhuri saying prominent trabecular pattern, Afreen increased trabeculations and Abhijit with the increased trabeculations and subperiosteal resorption. So we have the next radiograph here. Ahmed, lace-like trabeculation. Yes, what do you see in the radiograph of the skull? Somebody says salt and pepper, very good. Pepper pot, Himani, yes, good. Again, very good. Anything else that we can pick up besides the salt and pepper appearance? What does the salt and pepper appearance actually signify? I would like to know that. We have somebody saying that there's a thickened calcareum, but no, there is no thickening of the calcareum and there's no widening of the diploe. Anybody would like to say what the salt and pepper? Yes, we have Madhuri again saying there are small widespread lytic lesions. Very good. They are circumscribed. They are no, it's not circumscripta. Okay, I come to the next radiograph, right? The next radiograph is that of the pelvis. Now, we already know that there is a generalized osteopenia, which we've seen in the previous radiographs. We know that there is a subperiosteal resorption. Now, increased trabecular, yes, bone resorption. That we have multiple lytic lesions, yes. So, increase end osteal resorption, yes. Who was that? I think Divya was saying that there's an end osteo, very good. And Himani says that there's a lytic lesion in the right pubic bone. We have some excellent audience out here. And yes, I don't know the name, but by Vivo does come up with a brown tumor, and Ashok says intracortical resorption. Very good. That's absolutely marvelous. And yes, we have all nearly reached up to the diagnosis, and that is hyperparathyroidism, which many of you have answered correctly. So, uh, actually, this patient was referred to me for the MRI of the spine. So this is what we actually, sadly, these days with MRI and CT, people keep referring to you for MRI or CT, not getting the radiographs done. All these radiographs were actually ordered by me after I had done the MRI of the cervical spine. So can you just see the cervical spine, and can anybody pick up a lesion why I ordered for these radiographs? The patient has presented with vague aches and pains. Patient had actually got a whole spine done. And yes, there's somebody who's come up with the answer. I'm trying to wait for more answers before I speak out the names. Um, Good. I know one person who's answered correctly. I'm still waiting for others to pick up why I actually wanted to get the radiographs done. So when I saw this radiograph, yes, we have two people who, one is Vivo again, and Swaroop, yes. Then we have Ajay saying there is a lesion below the thyroid gland. Then there is some A which says a parathyroid adenoma. Very good. So you see, there is a lesion out here which should normally not be done, right? Now, in all cases of my spine, I always add a coronal section, right? So here I did this coronal section. I took it a little ahead. Normally, we don't take it so far ahead when we're just covering the spine. And look at this lesion out here, sitting right here. Okay. So after this MRI, we did all those radiographs, which had a very classical appearance of hyperparathyroidism. And this is the systemic scan in which you can see there is a hot spot at the level of the parathyroid gland, and this did indeed turn out to be a parathyroid adenoma. So, we have all picked up nearly all the radiographic findings which were there in those radiographs. And the most common abnormality in hyperparathyroidism is actually bone resorption. And this is an acronym actually which has been contributed by my friend Dr. Rakhi. This is peptic LT, to just remember what all type of resorptions you can have. P stands for some periosteal, E endosteal, again a P for subphyseal, then trabecular, intracortical, subchondral, subligamentous, and subtendinous. All types of resorption can be seen in hyperparathyroidism at different areas. Then other tumors, other lesions is brown tumors, and then you can also have osteosclerosis. And remember that primary hyperparathyroidism can also be associated with CPPD and rarely with gout. So just to show you, this was the initial radiograph, and a zoomed up view shows you here. Now, whenever you look at a radiograph, and if it's for the bones, remember, first thing that should actually strike you is the bone density. But even with that, you have to be careful, because with the digital systems coming in, your technician can sit at the console and just change the density at will. So besides looking at the density, look at the cortical margins, right? Whether you have sharp cortical margins, and in this case, you were very clearly seeing the subperiosteal resorptions, and this is more common on the radial side of the phalanges. Next thing that strikes you is the marked coarsening of the trabecular pattern, right? So what happens is there's a trabecular resorption as well. So the primary trabeculae become more coarse. And one person in the audience had picked up that there is also, see, the tuft is also becoming quite blurred, right? This is the very initial stage of acroosteolysis. So all this was what you could see on the radiograph of the hand, right? Then the next radiograph that we had, okay, there is a radiograph just to give you a differential. Now, in this also, you see that there is a coarsening of the trabecular pattern, but see the cortical margins are quite sharp. There is no superiosteal resorption. And an important point that I want to show you is many people usually don't understand when you say that there's a loss of undertubulation, right? So this is what you get a this is what happens. The tubule, you get this type of a shape. You get a waist-like appearance, and here you have there is a loss of that waist-like appearance, right? So this was a case of hematopoietic disorder, and in which you have this loss of this undertubulation and this coarsening of the trabeculae, and this was a case of thalassemia. Okay, and the next thing that we saw was a radiograph of the pelvis. So here I want to show you that there is a intracortical resorption. Now, can you see these tunnel-like lucencies in the cortex, which were also called cigar-shaped lucencies? So this is intracortical resorption, right? Again, this is quite very, very prominent in hyperparathyroidism, but remember it can occur in very rapidly occurring osteoporosis also. So besides that, I'll show you other areas where you have to look for resorptions. You can have subligamentous and subtendinous resorptions. Now you see this resorption at the trochanter and the ischial tuberosity, right? And another resorption that you can see at the undersurface of the clavicle, and these are the areas where the tendons and the ligaments attach. So these are the common areas where you can have these type of resorptions. End osteal resorptions, right? You can see the end osteal resorption here at the level of symphysis pubis, at the level of the sacroiliac joint, and here in the acromioclavicular joint. But remember, there is always a differential diagnosis of multiple myeloma, and you have to rule that out when you see this. Then cancellous or the trabecular bone resorption is what gives you the salt and pepper appearance of the radiograph. Now, somebody had mentioned that there is a widening of the diploid. Remember, see, there is no widening of the diploid here. There is no hair on end appearance. This diploid is very much normal. And this is the classical trabecular resorption. Besides that, you see these scattered lucencies, which are due to the Brown's tumors. Now, again, a differential diagnosis of multiple leucine lesions is multiple myeloma. But here, see, they are discrete punched out lucencies, and you do not have a background of a trabecular resorption. Just look at the diploid normal and diploid normal. No thickening of the skull base. There's absolutely normal skull base out here, right? And one other important point that you should look for when you thinking of hyperparathyroidism is loss of lamina dura in the mandible. Now, this is just to show you what a lamina dura is. This is a thin cortical. You can see this sclerotic line over here. There is a loss of lamina dura when you see the radiograph of the mandible. This again can also occur in multiple myeloma. Then Brown's tumors, you can have them in the intracortical location, you can have them in the intramedullary location. These are usually lytic lesions, but in the later stages, they can also present as a mixture of sclerosis and lysis. So we come to the next case. This is a 1.5 years baby boy presenting with delayed walking, delayed dentition, and failure to thrive. You are provided with radiographs of the pelvis, lower limbs, hand, and chest. Remember, I want the findings and not directly the diagnosis. Okay. So the first, we have this radiograph for you. Uh, somebody's just said, okay, I hope you can all hear my voice. Uh, okay, we
Yes, ma'am.
have.
Voice is clear.
Okay, then we have multiple fractures. SS is mentioning that. Ahmed is mentioning a metaphyseal splaying. Then we have others coming in with Kushbu and Ashwini and Vivo. Metaphyseal widening, fraying. Divya says there's a pencil thin cortex of the tibia. Very good, very good. I'm quite impressed actually. So then, yes, we have SS saying fibular deformity, and Boeing is, I think, what you want to write. There is a very good, Renu has come up with what I actually wanted it to. The first thing is that there is a diffuse osteoporosis. Afrin says there's a fracture of the right tibial shaft. Subperiosteal thickening, I fail to see that. Somebody has mentioned it's osteogenesis imperfecta. It is not. So we'll try and find out why it is not. Subperiosteal calcification, no. But yes, Sumitra says fraying, splaying, and cupping with fractures. I'll come to the next radiograph. and that is the wrist with some part of the forearm. Please, Ankita, let me know whenever I need to stop. I've got 8 cases, so if we can, if the time is up by wherever, you can tell me to stop.
Sure, ma'am.
Uh, Now there is Dewey saying metaphyseal fraying and pathological fracture. Then Sumitra saying blurred and widened growth plate. Very good. There is Divya says yes. There's a bowing of the ulna. Ritika non-healed fracture. And just a minute. Yes, most of you have come up with the metaphyseal fraying. Yes, good. And first metacarpal destruction, no, I would not really call that a destruction, but yes, you at least you've picked up something which I'm very happy about, that you do find that there is something abnormal there. That was then we have widening. Ahmed saying widening first and second metacarpal green stick fracture. Good, Himani, that you labeled it as a green stick fracture, which I really wanted. And yes, there is a delayed appearance of the epiphysis. So we next go to the next. There we have. I hope I've not missed any. Okay, no. Now we have the chest. Why I'm saying it's a bell chest. Okay, good. Sumitra saying there's a bulbous enlargement of the costochondral junction. A saying beating of the ribs. Good. Renu saying again anterior rib widening, widening. Yes. Rachitic rosary. Abhijit. And very good. Somebody Madhuri picked up the fractures in the humerus. Very good. Thickened ribs, multiple fractures. Yes, good. Ashwini, and yes. No, then somebody said it's a dysplastic clavicle. No, it's not a dysplastic clavicle. So I think again, most of you have picked up the findings that I really wanted you to pick up. And yes, the diagnosis is rickets. So in vitamin D, we all know, maintains the normal serum calcium levels and it activates the osteoclast for bone resorption, but it increases the absorption of calcium and thus it aids in the mineralization of the osteoid matrix. So, so whenever there is a defect in vitamin D metabolism for whatever reason, there is a delayed mineralization of the newly formed matrix. Now remember that the matrix gets formed by vitamin C and mineralization of that matrix is by vitamin D. So what happens is, why do we get all that widening of the growth plate is that we do have a matrix which has been laid down, but it is not getting mineralized, right? So you see that there's a lot of matrix here, but it is not getting mineralized. Then this formed matrix, it again impinges or it tries to impress upon the already softened bone, and therefore you have a splaying, a fraying of the metaphysis and a cupping of the metaphysis. So this is, once you know what is actually happening, then you will not have any difficulty in picking up your findings. So what do we have, the different findings? We have a widening of the growth plate. There is an irregularity or loss of the zone of provisional calcification. Since there's no calcification occurring, you will not have a zone of provisional calcification. Then widening and cupping of the metaphysis. In infancy, you can have skull deformities like the craniotabes and softening of the skull. Then because the bone is so soft, you have bowing deformities. And then the green stick fractures. What are green stick fractures? Which involve one cortex and do not reach the other cortex, right? So those are green. Then you have the rachitic rosary, the pectum carinatum, scoliosis of the spine because the spine becomes soft. The ballooning of the disc, again because the bone is softened, the disc, it impresses upon the end plates and becomes balloon shaped. You have a triradiate pelvis. Now, one finding that I wanted you all to pick up in this radiograph was the slipping of the capital femoral epiphysis. So remember that you have to look from one end of the X-ray to the other end so that you do not miss any finding. Okay, so we have nearly everything in this radiograph, and this is all to begin with on a background of osteopenia, right? So remember, density of the bone is the first thing that you should notice. And again, you see there is a winding of the growth plate, there is a cupping of this Metaphysis. Now, somebody had picked up this that there is a metaphysial. Now, what happens in this metaphysis? Again, there is a coarsening of the trabecular pattern, and the metaphysis, even here, they are all cupped and frayed, and there was a delay in the appearance of the carpal epiphysis. And this is what I talk about when I say about the green stick fracture. You have it here on the radial side, but it is not reaching the medial cortex. And there is a bowing of the bone because of the softening of the bone. Now, just a differential, just to show you another radiograph in which you have metaphyseal lucencies, say, but then you do not have rest of the findings, right? There is no metaphyseal bowing, cupping or fraying. This was a case of leukemia. Now, somebody had mentioned osteogenesis imperfecta. Yes, you do have osteopenia in that. You do have multiple fractures in that, but you do not have all these findings, that the widening of the growth plate or the metaphyseal changes that you are seeing over here. So this was a case of leukemia with metaphyseal lucencies, just to show you a differential. Now coming to the next, that is case 3. There's a 42 years old, non-athletic, non-obese man presenting with frequent backache and stiffness. There is occasional pain in the knees. Patient is HLA-B27 negative. So this is the first radiograph that I'm showing you, that is of the spine. So can we have the comments, please? The second, Joey had said for there was a question about second. I think I've answered those questions, the question which are uh, have been put up. Okay, now for this radiograph, there are reduced disc spaces. Yes, very good, Khushbu. And reduced joint space with intradiscal calcifications, Anabarasi. Yes, Anbarasi. Madhumita has come up with a diagnosis. I said, I don't want a diagnosis, please. I want the findings first. Calcification in the disc, good. And plate sclerosis, good, yes. Uh, then Soumya says platyspondyly. Okay, maybe the radiograph has been projected that way. Now, somebody says syndesmophytes. Remind me to tell you the difference between syndesmophytes and osteophytes. Or I could say that even right now. Now, somebody says marginal osteophytes, good. Osteophytes, Deepak says marginal osteophytes. Ganesh says central disc calcifications, all very good. I don't want the diagnosis just yet. We'll reach there soon enough. Okay, now we have, yes, osteopenia, very good. Zoom user says osteopenia again, which is the first thing I actually wanted everybody to notice. Now we have this radiograph of the knee. Please come up with meniscal Sumitra, Ganesh with meniscal calcification, Madhumita, very good. Soft tissue calcification, whether if you mean meniscal calcification, yes, we have many of them coming up, right? Now, yes, okay. Now I have this radiograph taken of the patient himself. So can you tell me what are we seeing? Why did I take this photograph to show you all? Anybody can tell me this? So this was to show you the pigmentation here in the sclera. So this pigmentation can occur because of deposition of, and the yes, it is alkaptonuria. We now have the diagnosis, which yeah, many of you had already talked about this before. Now, just to show you so that I don't forget later on, what is the difference between syndesmophytes and osteophytes? Now, remember that whenever there are osteophytes, their attachment to the vertebral body is horizontal, right? And when you have syndesmophytes are actually ossification of the anterior longicular ligament, and they are vertically oriented. So whenever you have a confusion as to whether these are syndesmophytes or these are osteophytes, remember, say that orientation. A syndesmophyte may go down and then unite with the other and give a more horizontal appearance later on, but the attachment to the vertebral body is always vertical. So syndesmophytes is what we see in ankylosing spondylitis. These are osteophytes, and this is a rare hereditary disorder. We all know there is a insufficiency of homogentisic acid oxidase, and this homogentisic acid is deposited in soft tissue, what I was trying to show you in the sclera, and is excreted in urine. And so if you ask the history of to the patient that if the urine stands for a longer time, does it become darker? That is very, very characteristic of this condition clinically. And in the radiographs, what do you see? You see degenerative disc disease and calcification in a younger patient, right? The patient is not that old to have such a lot of degenerative diseases. And then you also have degenerative large joint disease, the knees, the shoulders, right? So hips, the chondrocalcinosis. So besides the menisci, you also notice that there is spiking of this tibial spines here, and so this is early osteoarthritis that the patient is having. Okay, so again, in a younger patient, you have a degenerative disease of the root joints and universal disc calcification. Think of ochronosis and try to take the clinical history. Coming to the next case, 51 years old lady was referred for evaluation of pain abdomen, generalized bone pains, stiffness at the hip and knee joints, and loss of appetite. You're provided with radiographs of the spine, and later on I'll show you a CT picture. So what do we see here? You remember to the findings is what I require. Okay, what do you mean when you say a rugged Jersey spine? Yes, Divya says it's end plate sclerosis. Yes, again, Madhumita and Sumitra. Yes, there is, and yes, Afreen is coming out with marked atherosclerosis of the aorta, aortic calcification, SS. Yes, good, very good. Peripheral sclerosis with central lucency, yes. So we have sclerosis of the upper, superior and inferior end plates, and we have vessel wall calcification. Very good. I think we have an absolutely marvelous audience out here. Somebody says it's a vertebral body enlargement. No, I'll show you some case of vertebral body enlargement later on as I go further into the talk. Now I'm showing you the CT picture of this patient. The CT picture, what do we see in the CT picture? Can you please come up with your answers? What am I trying to show you? Look at everything if you. So, yes, ivory bone, I would rather say that we have an osteosclerosis. Yes, we have a sclerotic bone. Now, all the cases that I'd shown you before were all osteopenic. Now we have osteosclerotic type, and somebody says, yes, there is a heterotrophic calcification. Madhumita, very good. iPhone also says there's a soft tissue calcification, and yes, many people have come up, but I need something more than what you have all mentioned so far. Why have I showed you such a, I mean, look at something else besides the bones. Besides the bones and the soft tissue scan, yes, SS says there is a kidney, yes, look at the kidneys, very good. So we have bilateral hydronephrosis, hydrouretus. The right kidney is appears to be small in size. So what do we see? And yes, somebody says, Renu says there are vascular calcifications also. Absolutely amazing, a very good audience. So we see that there is an osteosclerotic bone disease. The bones are sclerotic. We have the rugged Jersey type of spine, and we have metastatic calcifications in the pelvis around the knee joints. We have aortic calcifications, and we also see that there is a chronic renal disease. Okay, so this is renal osteodystrophy secondary to kidney disease. Absolutely good. We have Madhuri, we have Saraswati, iPhone, all of them coming with the right answers. So, as we have all seen, that it refers to a bone disease seen in chronic renal disease, and findings are those that due to secondary hyperparathyroidism, sclerotic changes are more often seen, because the contrary to what we think, parathormone primarily acts first on the osteoblast and then acts secondarily on the osteoclast. And then the sclerotic bands at the superior and inferior end plates is what gives rise to the rugged Jersey spine and other features of osteomalacia. And remember to see the soft tissues is what I'm trying to impress here. You can also get a mixture of osteoporosis and osteosclerosis, and you may also have fractures because the bones are quite brittle in such cases. Coming over to the next case, that is case 5. A 40 years old lady went to a dentist with discoloration of teeth as her primary concern. There were also symptoms of backache, joint pains, and for which radiographs of her spine, pelvis, and forearm were ordered. Right? So, if I insist on everybody taking and listening to the history, because sometimes the answer is in the history itself. So, what do we see in this radiograph? Again, I want the findings. No diagnosis, please. I want the findings. Yes, again, we have an osteosclerosis. Anbarasi, Divya, Himani, Khushbu. Yes, okay, we've all decided there's an increased bone density, right? Now, besides that, what else do we see? So you come up with bridging osteophytes. Yes, anterior longeal ligament calcified, Khushbu, very good. Now, this is what I call is that there is a ligamentous calcification. Again, now next we come to the radiograph of the pelvis. What do we see there? No, it's not Shearman's disease, please. We need to know what is Shearman's disease. Okay, now coming to the radiograph of the pelvis. What do we see in the pelvis? Come on, fast, fast, fast. It's quite very good. Lumboilial ligament calcification A. Good, good, very good. I like that. No, I don't. Okay, if you want. Yes, there's an implant in the left femur. Right, good, good. Again, I don't want the diagnosis, please. Diagnosis will come to afterwards. What else besides? There's a sclerotic and there is iliofemoral ligament calcification. Anything else? Anything else we need to see? Anything else we need to see? Do you pick up anything over here? What would you think? What do you think that there is something wrong here? Do we normally see this? What is this? Uh, Obturator membrane ossification, right? So this is the iliolumbar ligament. Okay, this is the obturator membrane, and this suggests that there has been a fracture earlier. So this is actually a brittle bone. And now, what do we see here? No, I wouldn't call it a candle wax appearance. We can't mix two pathologies, right? We are already on a certain thinking on certain lines. Yes, very good. iPhone, interosseous membrane calcification, absolutely perfect. That's excellent. So we have a sclerotic spine, we have ALL ossification, and we have ossification of the iliolumbar ligament and the obturator membrane and the interosseous membrane ossifications. Yes, now I am glad that you all have come up with the diagnosis of fluorosis. We have Rushikesh, Madhuri, Abhijit, Anbarasi, and many others who had initially also suggested it as fluorosis. So this is actually a case of fluorosis. And these are the typical findings. Now, one thing I wanted to show you was the some periosteitis, right? So the periosteal, you can see some periosteitis out here, and rest you've all picked up. There is now trabecular blurring, right? Now in the initial stages, this is of course an advanced stage. In the initial stages, you may just have a trabecular coarsening also before all the sclerosis sets in. So we have ligament ossifications and we have interosseous calcifications and periosteal bone formation. Okay, so this was a case of fluorosis. Uh, it is a chronic metabolic disorder caused by ingestion of large amount of fluoride, mainly in drinking water. Now, I am based in Amritsar, and we have a district here, which is Patti district, which has a lot of fluorine in the drinking water. So we keep getting such cases quite frequently, and there is an increased metabolic turnover of the brain, right? But the bone that is formed, it is actually a brittle bone. So that is why you have fractures, and that is what I was trying to show you, that patient already had a fracture of the neck of femur. Now, the next case, I'm just going reverse this time. I'm going to show you an MRI because the patient was referred to me for MRI. And I keep telling you, people always send for an MRI before they're going for anything else. But this case was justified because a 4-year-old boy had presented with progressive painless loss of vision in both the eyes. and MRI was requested for MRI of the brain, and I'm just going to show you the MRI that we did. So just tell me what you are seeing in this patient. You take your time, look at everything, try to remember the history. 4-year-old child presenting with blindness. There is a thickened and tortuous optic nerve on right side. I don't want a diagnosis. I want, yes, there is a hyperostosis. Good, Aniket, sorry. No, there is no J-shaped cella. Um, I think A wants to say a thick base of skull. Uh, Loss of normal signal in, what do you say? What do you want to say about loss of signal in the optic nerve? I think you should comment more about that. Hypoplastic, no. There is a thickened calvarium and base of skull. Good, Madhuri. So yes, A says there is a narrowing of the skull foramina, and iPhone says yes, there is a narrowing of the optic foramina. That is what I'm trying to come at. Why am I showing you the optic canals here? See, these are the optic canals. There is a generalized thickening and sclerosis of the skull, right? Now, next time you go and look at the skull, look at the bones, okay? You have some fatty marrow in the, normally in the diploid, right? But this is all sclerotic bones, the base of skull, and you see that there is an encroachment. Look at the encroachment of the optic canals. So what are they doing? They're compressing the optic nerve. The optic nerve actually appears bright. That is why I've shown you this fat suppress sequence to show you, one, here there's a compression, and second, here there is a bright signal of the optic nerves. The optic nerves are being compressed. So when I saw this MRI, I knew I was dealing with a bone disorder. So I asked for x-rays of the patient, and I'm going to show you the x-rays. So after the MRI, we got x-rays done, and this is what I see on this. So please give me the findings. Findings, please. Findings. What do you see in this radiograph of the spine? Uh, hmm, no, they are not. There is an increased density. SS is right. Sumitra is right. And though Divya, no. Okay, there is an increased density. So we have Madhumita and a Zoom user and 123 all saying that there is an increase in the bone density. Any particular type of look, what we call this type of look, the bones, like you have the rugged jersey spine in renal osteodystrophy. What type of appearance would you call this? Okay, a bone within a bone. What would you like to call it? Would you call it a sandwich appearance? Do you think it looks like a sandwich? You have this end plate sclerosis and a lucency in between. So, right, this is a sandwich type of vertebra. And next we have the base of skull, right? So, what do you want to say? Do you want to confirm your findings on MRI that we saw that there was a generalized sclerosis of the base of the skull? That is what we see in this radiographs of the uh, yes, okay, yeah, the PNS, they're not well pneumatized. Okay, that is okay. But the thing I really want to show you is the generalized sclerosis of the skull base. What do we see in the next radiograph? What do we see here? Yes, doing brilliantly well so far, and yet there is a sclerosis. Good. Ritika says there's a sclerosis. I haven't yet shown you the. Yes, A says there's a loss of medullary cavity with sclerosis. Very good. That's actually what I'm trying to come to. That there is a thickening of the bone sclerosis at the expense of the medullary cavity, right? So the next, what we see, do we see any bone within a bone appearance? Would you see? Can you see this bone within a bone appearance? So this is what I'm trying to highlight, that what you are saying is a generalized increase in bone density at the expense of the medullary cavity, and you are having a bone within a bone appearance. No, we have another, yeah, we have another radiograph here. So somebody had mentioned earlier that there is an Erlenmeyer-Flass deformity. I think someone up there had did mention that. Okay, so what is the Erlenmeyer? Again, there is an undertubulation, right? Yes, there is a metaphyseal widening. Normally, you have a waist over here because of the undertubulation. That waist is lost, and you have a flask-like appearance. So this is an Erlenmeyer flask deformity, and here you are also getting a bone within a bone appearance. Can and again sclerotic bone, but a brittle bone. So you also see nobody picked up this fracture. So I would like you to see that there's a fracture of the fibula. Anybody would like to give me a differential diagnosis of an Erlenmeyer-Flass deformity? Quickly, 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 because I think I don't know whether we are actually having more time to show you more cases. Uh, anyone? Yeah, Gotcher, very good. Sumitra, good. Gilbert says Gotcher, Gotcher, very good. Thalassemia, Gilbert, yes. Absolutely, yes. And then you can have that in lead poisoning also. So I'll come to the next. This is a case of osteopetrosis. I've all discussed all the theory while I was showing you the cases. So now we come to an elderly 68-year-old female who has presented with new onset of back pain. There is no history of trauma. So it is a chronic pain which has become severe lately. So what do we see? Osteopenia, very good. That's what I liked everybody to notice. Madhuri, Tanvi, SS, there is osteopenia, and SS also says there is a wedging. There is an end plate collapse. Very good. So there is a generalized osteopenia due to osteoporosis. There is a collapse of the vertebrae, and there is a bowing, there is a increased kyphosis of the spine. Very good. We have Afreen and Sumitra coming up with that. So this is actually a case of postmenopausal osteoporosis. Right now, what I want you basically to see is that besides the decrease in bone density, what you should see is the thinning, the pencil thinning of the cortices. Okay, the cortex is well seen, it is sharp, but it is thinned out. The trabeculae, they are all coarse. Okay, so there is significant trabecular thinning, and there is an increase in the fracture risk. You can have different types of osteoporosis: generalized, regional, localized. And see, what you see is the increased radiolucency, cortical thinning, altered trabecular pattern, and fractures and deformities, which we've seen all of them in these cases. The trabecular bone changes are more prominent in the axial skeleton. Just to show you that this is a normal radiograph of the vertebra, and see the density and see the cortex. Now what happens is, initially there is a rarefaction of the horizontal trabeculae and the vertical. Now this is what mesh like thing appears. So when the horizontal trabeculae start getting resolved, you get more prominence of the vertical trabeculae. Now if you look at this pattern, so now you know what is actually happening here. So there is a coarsening of the trabecular pattern, and there is a resultant decrease in height because the bone has become weak. Similar things happen here. You have a primary group and a secondary trabeculae, both the compressive and the tensile groups. So there's a Ward's triangle, which is a lucency you get because of these trabeculae here. So when these trabeculae start getting rarefied, the secondary trabeculae start getting rarefied, the primary become more prominent, right? So here you see that the primary become more prominent because the secondary trabeculae have rarefied, and this Ward's triangle becomes more prominent. And do not mistake this for any lytic lesion. This is a feature of osteoporosis. And then you can have, of course, bone resorption at the endosteal and the periosteal surfaces, as well as in the intracortical regions. So these are regional osteoporosis here because of the amputation that you can see, and there is a regional osteoporosis because of a fracture and disuse osteoporosis. And you can have a localized periosteus osteoporosis in a patient of rheumatoid arthritis. See the very classical juxta-articular osteoporosis. So just to show you the osteoporosis, a last case I'm going to show you is that of a 45 years old housewife. Diffuse bone pain for 6 months, progressive muscle weakness for 4 months, and difficulty in walking and climbing stairs. And this is the radiograph. I'm going to show you the main radiograph, right? So what do we see here? Quick, quick, quick. Osteopenia, very good. Fish mouth appearance, very good. So we have Gilbert and with osteopenia, and Kushbu with again decreased bone osteopenia. And what else? So what do we have? There is a generalized osteopenia, but there is, and again, this is what we call as ballooning of the disc, because the bone is weak and the disc, they impress upon the end plates, and which gives us the balloon shaped type of a appearance. And remember, when we saw that osteoporosis, there was a pencil sharp cortex. Here there is a coarsening of the cortex, right? So this is the radiograph of the pelvis. So what are your what is your findings? What are your findings? I need all the findings very fast. Come on, come on. I know you can all see them. You're all doing really loser zone. Very good, KP Srushi. But let me know where you see the Vivo also says losers. Where are you seeing all those loser zones? Tell me where they are. Where are the loser zone that you have seen? Yes, very good. Left femur is Anbarasi. Madhumita says both the femurs. Medial cortices, Madhumita, Sumitra. Renu says vestibular protrusion. Very good, very good. I'm quite happy with the answers. Anything else? Again, somebody has to point out that there is a generalized osteopenia, right? There is a generalized osteopenia. Then you have, there is the coarsening of the trabecular pattern, there's a blurring of the cortices, there are multiple loser zones, right? See, multiple loser zones. Where else will we look at for the loser zones? At the rami, the pubic rami. See the pubic rami. See the shape of the pelvis. See, you see the triradiate inlet pelvis, right? So we are all supposed to look at these findings, and then coarsening of the trabeculae, yes. And so we come up with the diagnosis of osteomalacia. Again, I will not go into the details of what it is, but just that you know that there is a coarsening of the trabecular pattern and there are fuzzy margins in contradistinction to osteoporosis, and the common locations of the insufficiency fractures or the loser zones are the pubic rami, the axillary margin of the scapula. I'll just show you the femoral neck, the ribs, and the posterior margins of the proximal ulni, and there are bone abnormalities due to softening. That's why we had the protruso stabili and the triradiate type of pelvic shape. Just to show you a loser zone in the scapula. So please, you have to look at these areas. Remember to look at these areas, loser zones in the ribs. So these are the areas that we miss actually, right? So whenever you're looking at your X-ray chest, remember to look at the ribs, remember to look at the lateral margins of the scapulae. So this is where you may just pick up. So just to tell you that there is just a very simplified approach when you think of metabolic bone disease. Either there is an osteosclerosis, which is because of an increase in the bone production, or there is an osteopenia, which is due to increase in the bone resorption or a decrease in the mineralization. So if you just narrow down it to the sclerosis or penia, you will narrow down many differential diagnoses. So Ankita, do you want me to go to the next 2, 3 slides, or do we wind up here?
Ma'am, I think we can take the last case because I think the
No,
question.
no, I think that no, there is no case. I want you to show the just the approach, like
Yeah,
what,
yeah,
how
ma'am.
do you
Sure,
approach?
ma'am. Sure, ma'am. Everybody would be interested.
Okay, okay. So this is, I want to show you the normal radiograph of the spine. Look at the density. See, you don't see the individual trabecules. Look at the cortices and look at the disc spaces, the curvature, and never ever to forget looking at the soft tissues, please, right? So now, just to show you what an osteoporotic spine looks like, there is a decreased bone density, pencil sharp cortices, decreased height, and a kyphotic deformity. In contradistinction, see the osteomalacic spine, you have the balloon discs, right, because of the softening of the end plates, and you have ochronosis here. Again, a young patient with osteopenia and advanced spondylotic degenerative changes, and there's a calcification of the discs. On the other hand, you have an increased bone density. There is ossification of the anterior longitudinal ligament. There is rugged jersey spine with sclerosis at the end plates, aortic calcifications, and again the sandwich appearance of osteopetrosis. So you should be able to know what we are dealing with when we see all these types. Now, somebody had mentioned the picture frame appearance and a Paget's disease somewhere. Just to show you why Paget's disease is different from all these, because in the highlight is that there is an increase in the size of the bone. Remember, the bone becomes larger in size and there is a trabecular, there is an coarsening of the trabecular pattern and there's a thickening of the cortices. Okay, so this is what we have as a classical Paget's disease. Approach to a chest x-ray. Now remember, I follow one way to do it, that either you go from inside to outwards or outwards to inside, so that, or you start from right to left or superior to inferior, so that you do not miss anything. So what all we tend to miss if we don't look at the corners is, this is the resorption at the end of the clavicle here. This is the subtendinous resorption at the tendinous attachments, the looser zones in the scapula, the looser zones in the ribs, right? The rosary, the rachitic and the scorbutic rosaries, which you see at the ends of the bones. So just don't forget to look at these areas, and do not forget to look at the spine, right? So many times you get certain clues just looking at the spine. And last but not the least, if you have a radiograph like that, do not forget to look at the information that you're being provided by the fractures in bilateral humeri over here, the green stick type of fractures. Okay, so that is the main concern. In the X-ray pelvis, again, a generalized look at the generalized bone density. This is a normal radiograph showing you the normal bone density and the cortices and the trabecular patterns. Try to look at these areas for any resorptions or any new periosteal bone formation, these areas for any insufficiency fractures or the looser zones, these areas for any end osteal resorptions, right? Do not forget to see the iliopectineal line or this drop sign here, right? And this is what you can lose when, see over here, there's a fracture, so there's discontinuity of this line. And in Paget's disease, again, you can see a coarsening of this, right? Then these are another area where you can have looser zones at the rami, looser zones. And here you have the endogenous resorptions at the pubic symphysis. Again, these are the areas for subtendinous resorptions. And you can have some fractures here, subchondral fractures, and you can have looser zones on this side as well as on this side of the femoral neck. So that is all, many things that you do have to look at when you're taking a look at the X-ray. And now we come to the skull X-ray. Look at the generalized shape, the diploid, the cortical margins, no coarsening, the size of the sella, the base of the skull, the PNS along with. Okay, and in this, what do we see? There's a generalized osteopenia. You are hardly seeing any mineralization. This was actually a case of infantile hypophosphatasia. No mineralization whatsoever, right? Pepper pot appearance of hyperparathyroidism with multiple uh, uh, Brown's tumors. Now, this is what is osteoporosis circumscripta in the initial, the lytic phase of Paget's disease. This is the cotton wool appearance of the sclerotic phase of Paget's disease. See the thickening of the cortices, right? That is what I'm trying to impress upon. And this is the case of acromegaly, in again which there is a generalized thickening of the cortical bone, and there was a pituitary adenoma sitting here in the pituitary fossa. So this is what I wanted to show you. This is a case again, the generalized thickness at the skull base and osteopetrosis. I think I'll stop here. Or
Yeah,
okay,
ma'am. I think
yeah,
so.
and I think yeah, we can just stop here, and we can cover this sometime else. Just to recapitulate, when you see a plain radiograph, look at the bone
I think
density.
there are few requests for approach to
Yeah,
and so I think if we can just touch upon that, I think.
okay, I'll go back. I'll just go back. So this is a normal radiograph of the hand. Okay. Now, as I keep saying, please do not miss the ends of any radiograph. the generalized initially to look at the density of the bone. Okay, and then the joint spaces. Here we know that there is an osteopenia. We can see that there is the cortex is blurred, there is a subperiosteal resorption, there is coarsening of the trabeculae, and as I said, this is the early stage of acroosteolysis. Don't forget to look here always, right? You may get some fracture here, some, so never stop looking. Don't stop looking at the soft tissues as well. I had shown you this radiograph, right? Okay, no, this I haven't shown you. No, here what we see is this is a case of, wait, just a minute. Okay, this is a hematopoietic disorder. Again, there is undertubulation. You don't see that waste. There is a coarsening of the trabeculae. So this was a case of thalassemia. A case of rickets. Again, somebody had said what was wrong with the metacarpals. I just wanted to show you that there is a coarsening of the metacarpals, and because of the much more prominent metaphyseal cupping and the metaphyseal changes, this is what it looks like. The metaphyseal changes here, growth plate is increased. There is a delayed appearance of the epiphysis. This is a patient of rheumatoid arthritis with a juxta-articular osteoporosis, right? The joint spaces are reduced. You see some erosions. I hope you can all appreciate the erosions. So you need to look at all these when you're looking at these radiographs. And this is a case of a patient with dense metaphyseal band, right? So this is a case of, there is an increase in the density here. So this is a patient of lead poisoning. So I hope I made things a little simpler. Just remember bone density, trabecular pattern, cortex, resorptions, the distribution of the disease, any resultant deformities, and last but not the least, look at the soft tissues. So it is really not very difficult if you know what to look at. Thank you so much.